on the blue port and the clear tube on the white port. Okay, you're all hooked up, you're all hooked up. Okay, on your desk or in the package was, can you hold that little adapter there up? There's this little plastic adapter, and we're going to need that as well. That's called a calibration adapter. And the sole purpose for that is it's going to allow us to put that flow sensor, that blue thing at the end of the circuit there, that's going to allow us to turn it around at some point and put it on the circuit backwards. If you try putting it on, taking the blue flow sensor off and putting it on the circuit without that adapter, you'll see that it doesn't work. And you don't have one. Okay. For some reason, somebody keeps stealing them. I had about 40 of them here before. So if you take this off the circuit, you'll see that there's no way to put it on without that adapter. And the adapter can go on in either direction. You can put it on this way or you can put it on that way. It doesn't matter. It fits either way. Okay. So everybody connected? Okay. So we're going to go back to the demo vent here. Oh, here's an extra one here as well. And there's a button down here that says pre-op check. You can see that. So if we press that, that's going to bring up 3 different tests, if you will. One says tightness, one says flow sensor, and the other one says O2 cal. Yes, sir. Sorry. Did you find it? Okay. So the first thing we're going to do, and I'll tell you in advance, so put the flow sensor on in the normal position, if you would. Yep. You can leave that adapter on, but just turn it around the normal way. Okay. The first thing we're going to do is the tightness test, and I'll warn you in advance when we hit that, it's going to take about 2 seconds, and you're going to hear a really loud noise. So be prepared for that. And what that loud noise is these ventilators are capable of a very high flow rate, about 260 liters a minute. So what you're going to hear is 260 liters a minute of flow coming out of the end of that circuit. When it starts to get really noisy, what we're going to do is cap the end of it and hold it capped until, and you'll know when the screen will change back and it'll give you a little check mark and a date and a time stamp. So I'll do mine first to show you. I guess it would help if I hooked everything up. That's always embarrassing. We're back to pilot error here. Oop, where'd my tube go? I'll get mine started and then you guys can do yours as well. Come back wherever you are. Okay. If the screen probably disappeared, so you just touch the pre-op check button again, and then we. What is the time limit on that? On what? 30 seconds. Yeah, I think it's 30 seconds. So I'm going to touch the tightness test. Now I'm going to occlude it, and it'll tell you down there underneath the little time bar. And so keep it occluded. And you'll hear the vent cycle the expiratory valve. And then you'll get a check. You'll go back to that screen and it'll give you a green check mark and a date and a time stamp. If you did it wrong or it leaked or failed for some reason, you'll get the nasty red X. That means you have to stay over 10 minutes extra later. Okay? Everybody get a green check mark with their tightness test? Okay. Put that airway adapter on, now the calibration adapter, and then if you hit the flow sensor test and just read under the time bar, first it's going to check, you have to start with it open to room air. For both tests, you have to start with it open to room air. So go ahead and hit the flow sensor calibration and read under the little time bar and it'll tell you what to do. So when it says turn the flow sensor, pull the adapter and the flow sensor off and put it on backwards. Or if you started with it backwards, that's okay too. Just don't put your hand over the opening, either when you turn it or afterwards, because you can use it to do your hair if you want. Well, most of us can anyway. Notice that I'm at least 3 cables away and I have a bottle of water should that be necessary. Huh? Uh-oh. Okay. So we've got everything plugged in properly. So, turn flow sensor. Usually what happens is people put their hand over the end when they're turning it. So the easiest way is to grab it like that, or just grab it so you're not putting your hand over the end. So don't turn it till it tells you, and then turn it back, and then you should be good to go. Unless you broke your membrane while you're putting it on. That's always possible too. Yeah. So when that elapsed time bar gets about 50% of the way through, then it's going to ask you to turn it back and then just reverse the process. Just take the whole thing. You have to take that part off too. Oh, yeah.
Are we going to have to do this on every patient?
Between patients, correct. Now, it's cumbersome now because you haven't done it before, but in reality, and when Daniel was here yesterday, we were having a long conversation about this whole thing. Putting the circuit on, doing that and everything, it's going to take you about 2 minutes. So,
can this be done?
And make sure
correct.
it's
Well, because it's a disposable device, and so, you know, could you use it, which I'm not advocating you do, could you just put the circuit together, put the flow sensor on and start ventilating? Yeah, probably work fine. But your volumes might be off a little bit.
So can this be done after the transport?
Yes. So you could actually, and that's what they do in the hospital, you know, after they use the ventilator, they clean it, put a new circuit on, do that, and then they turn it off and let it sit for a minute, 10 minutes, a week, a month, a year, whatever, and when they turn it on, they're good to go.
It's ready to go.
It's ready to go, yeah. So it's just a one-time thing. Did everybody get check marks? Everybody done? Okay, so you'll notice on that airway adapter, yours came out okay too?
No, if we say with your morning rig check,
Yep.
you hook up the circuit, you do that. If you disconnect the circuit, do you have to recalibrate?
As long as you put the same circuit back on, no. The issue has come up though about, so you've technically taken something that's sterile out of the bag and you potentially contaminated it, and then, so, I mean, you could do any or all of those things. It's not really a fill question, it's more of a policy about, you know, how you want to do it. Obviously, it comes with that little, if you get these coaxial circuits, they have that little blue cap, so you could, what I would do in that case probably is do the flow sensor calibration first, and then when you go to do the tightness test, take that little blue cap and put it on, and when it's done, don't uncork it anymore, and you're good to go then. Okay? So the little, if I could just borrow yours for a second, the little adapter has a little clip on it, and you could clip it on to that blue or clear tube, but being a betting man, I'd guess within 15 seconds that thing's going to get knocked off and roll somewhere under a counter or off the helipad or whatever. So and it's 90. If I said you'll never need it again till the next time you calibrate one, the next time you used it, you'd be prompted to calibrate the flow sensor. So what I suggest is just pull either the blue or the clear tube off, feed the adapter through onto the adapter onto the hose, and then reconnect the hose. And that way, in the rare instance you would need it again, you're going to know exactly where it is. And then when you, after the run and you're pulling the circuit off, just pull everything off together and throw it away. Okay? Okay, so now we're going to talk a little bit about, we're going to get into how do we index the ventilator and the patient together. And that's done by, guess what, we already did it, the gender and the height. Okay? So hit the Controls tab on your ventilator. And if you look down in the bottom left-hand corner of the screen, again, it's going to show you that ideal body weight, which was 57 kilograms, right? What does it say right below that for the minute volume target? 5.7. 5.7. So there's kind of a universal rule, again, a generic standard based on metabolic demand and ideal body weight. Why do you use ideal body weight? Well, I'm 20 pounds overweight. Doesn't mean my lung volume changed. Just means I ate too many Big Macs and I didn't run around the block enough afterwards to work it off, right? Or I spend too much time sitting in my car driving from here to there, or what have you. But in any event, that's why ideal body weight is used, not actual body weight, because that's a better indicator and predictor of what pulmonary mechanics are going to look like. To that point, any patient who weighs more than 30 kilograms, their normal minute volume is 100 milliliters per kilogram per minute of their ideal body weight. You don't have to calculate that. Notice that if the patient's ideal body weight is 57 kilograms, if you move the decimal point one place to the left, you get 5.7 liter minute volume. So if I slipped out here on a banana peel, we found a rotted one before in one of those boxes. It looked like if anybody needs penicillin, it's in the garbage can over here. If I slipped in the hallway and banged my head and went unconscious and you nice people intubated me, my ideal body weight's about 95 kilos, put me on, what would my normal minute volume be? 9.5 liter minute volume. You can use that on any mode of ventilation, whatever you're doing. When you get below 30 kilos, the metabolic rate related to the ideal body weight goes up. So kids have a higher metabolic rate relative to their ideal body weight than patients that are 30 kilos and above. Okay, so if we go back to the controls tab, what if that patient was already on another ventilator and was already receiving an 8 liter per minute volume? We wouldn't want to put them on the T1 on ASV and transport them at a lower minute volume because they'd become hypercarbic, right? So with the control tab open, activate that percent minute volume, and I want you to turn the press and turn knob clockwise until you get an 8 liter minute volume, and then tell me what that percent minute volume is now. So if you did it right and you didn't change the patient along the way, you should say 140%, and the minute volume should now be 8 liters a minute. So the way that we're going to dial in or order the minute volume we want is by turning that percent minute volume control. Anytime you activate a control variable on the ventilator, it's going to show you at the 7 o'clock position and the 5 o'clock position around that what the minimum and the maximum value is that you could set that control variable to. So what's the minimum value that I could set that control variable to?
25.
Okay. What's the maximum PEEP that I could set this ventilator to? Got it. So you never have to guess about, well, how high or how low can I go? You just touch the button and it'll tell you. Okay. What if this patient needed a 12 liter minute volume? How would I do that? Let's do that. Everybody end up with 210? Now your protocol is, as I remember, going to say that you can dial in between 100 and 150 without talking to anybody. The question came up when Daniel and Matthew were here, or Matt were here yesterday, and we spent a fair amount of time talking about the protocol in addition to going over the ventilator, and because one of your peers asked a very good question, said, well, what if the patient's already on a minute volume that's higher than 150% of their predicted? So I think they're going to go back and huddle and discuss that. But if you were anticipating how you might feel when you get out on site, especially the first few times, if you would normally put a patient on a rate of 10 and a tidal volume of, say, 500, versus that patient was really sick and you had to put them on a rate of 20, would that make you feel clinically uncomfortable to have to do that? No. Well, going from 100% to 200% is exactly the same thing. So you shouldn't have any fear or trepidation about putting the patient on a higher percentage because the patient's sick, and that's what, by the way, what they're already on. Conversely, if you're transporting the patient and you're using end-tidal CO2, if the end-tidal CO2 value is too high, would you turn that percent minute volume up or down? Anybody want to guess? Turn it up. Because when we turned it up just before, our minute volume went up, right? So if you're increasing the rate on the ventilators you use today, are you increasing the minute volume? Yep. If you leave the rate the same and turned up the tidal volume, are you turning up the minute volume? So when do you turn up the tidal volume versus turning up the rate? Now we're going to get into what ASV is going to do for us, because you don't have to remember that. Okay?
What if the patient's being bag valve assisted when you get there? What is your? I don't want to hear the protocol because that's going to change.
Sure.
What is the recommendation from Hamilton?
For how to set that?
So we get there. Are we just going to set them at 100% based on their ideal body weight to see how they respond?
In lieu of having anything else, that's what I would do.
All right.
Mm-hmm. Or maybe 120%.
Most of the time when we're picking them up in the emergency department, the patient's not hooked to a ventilator. They're just being bag
Okay.
assisted.
Okay. So that would be, I mean, you might, as much as you can find out about the patient would lead you kind of down that road, a patient's febrile, the patient has bad pneumonia, you know that patient's not going to, their minute volume's not going to be normal, right? They have a big VQ mismatch, or they're hypermetabolic because they're septic, or, you know, patient's got a temperature of 104, you know, their metabolic rate's all jacked up. So I'd be careful starting at more than, say, 120, 130%, only because you don't want to. Now, if you have end-tidal CO2 or somebody's standing at the ready to do a blood gas, then, you know, put them on, wait 2 minutes and get a blood gas, and then adjust from there. But, you know, making 10 to 20% moves on that percent minute volume, you're not going to kill anybody. Be extremely careful, and unless you have a very good reason, do not turn it down below 100%. Okay, smart-ass Phil, why would you even have a setting that would go below 100%? And we're going to talk about that in a minute. And that would be for weaning patients or for known COPD patients. Does Sister Mary Holywater, who smoked 4 packs of cigarettes a day in the nunnery or what convent, whatever it's called, does she have a normal CO2? No. And what happens is if you hyperventilate, you ventilate those people to a normal CO2, then they pee off all their bicarb, and then you can't get them off the ventilator forever. So, okay. The other thing that we're going to show you, and I'm going to do it on mine, and we'll do some stuff on yours, but those rubber bladders are virtually impossible to show you some of the things that the ventilator is doing just because of the way they are. It's just basically a floppy bag. So if you want to buy one of these, they're about $800, and, you know, feel free. Medicine's worse than aviation with what things are charged for. So let's see what we've got going here. So our 57 kilogram patient, so I'm going to hit start. Okay, so some of the things that the ventilator is going to do for us is, in addition to ventilating the patients, it's actually going to be diagnostic. And if you'll notice right now, this display, which is the same one that's up on the screen, there are no, it's kind of a blank graph right now. And the reason for that is that in the initial 3 to 5 breaths that the patient is receiving from the T1, or any ventilator that has ASV on it for that matter, which is all of our ventilators, it's a little bit like turning on the shower, right? Do you turn the shower on, just jump in? No, you put your hand or your foot in to see whether you're going to be scalded or frozen to death before you get in and you make an adjustment. So those first 3 to 5 breaths are the ventilator basically testing the patient, learning the patient's pulmonary mechanics. And then thereafter, and that's typically going to be somewhere around 15 centimeters of water. Thereafter, the ventilator is going to present a few additional things, populate that display. That is the default display, by the way. And you'll have a red box, which is called the safety frame. Got an alarm going there?
I hit start.
Oh, premature button pusher right here. That's right. So the on-off button and the standby button are one and the same.
Ah, there you go.
No worries. Our first penalty box incurred. No problem. No. Well, you're free to leave if you want to. You walked in, it's just like marriage, right? You walk in through the door is always open. So what the screen is now displaying is a graph that plots tidal volume on the y-axis, the vertical axis, and rate on the x-axis, or the horizontal axis. I'll go over here. It might be easier to point it out here. And this curved line represents all the combinations of tidal volume and rate that'll produce this this is not your ventilators or mine, but when I was building the slides, I happened to have it on different patient size. All of the combinations of tidal volume and rate that will produce that 7.1 liter minute volume. And the safety frame, the red box, think of the area inside the box as safe combinations of rate and tidal volume to use on that patient with that patient's pulmonary mechanics. Now, it could be that the patient has lung disease, it could be that the patient has airways disease, or both. It could be that the patient's biting the tube, or they've slipped down on the gurney. All of the things we've already discussed. The shape of that box is going to help us tell what kind of patient we're dealing with. Okay? There's another display, so you can go ahead and get your ventilators running. Hook up your test lung and press start. And so when it first starts up, the alarm silence is going to be active. Yep, right here. Just press start. Yep. And you'll have You have no test lung.
Low minute.
Okay, there's our second infraction. Who's squeezing the bag? All right. That's right. Nobody's allowed to breathe because we have the alphabet soup and the beeper. It's like putting the bike together. What are those parts for? All set? Yep, you're good. Just take this off. You don't need that. Okay, so when you'll notice, did everybody notice that when they first turned the ventilator on and started it, that the ASV graph didn't have any red box, it didn't have any numbers on it, and now it has a red box and it has some numbers on it. Okay? Let's see why you guys are alarming here. That's okay, that'll correct itself. Those will all go away. So as you see on these guys' ventilators, there are some alarms when you first turn the ventilator on, but when you first press start, the ventilator automatically activates the alarm silence button for half of the normal time, which is 2 minutes. It activates it for 1 minute. And the primary reason for that is that some of the measured parameters, specifically minute volume and rate, are based on an average of 8 breaths. So when you turned it on, there was nothing for it to average, and so it waits for a few breaths before it can present numbers. And so if you didn't do that, when you turned it on, it would start alarming right away, which it was, but the alarms have since corrected themselves and gone away. Okay? So we're going to talk about, in a few minutes, how do we transition a patient that's already on a ventilator onto a T1 and onto ASV, and then also at the other end of the transport, you're going to have to give a report to the people, and they're probably not going to have ASV unless you're going to St. Rita's or some of the other hospitals. Grand Rapids has tons of Hamilton ventilators. So it's likely or possible, more often than not, that you're going to be picking up from and delivering to a location that doesn't have a Hamilton ventilator yet. I'm working on that. Stay tuned. So on the ASV graph, the green number there, that's the tidal volume, that's the setting, and that's the rate. Okay? So for extra gold star, and you could redeem yourself, get off the blacklist for that premature button pushing. Do you remember? Now I forgot the question. Okay, so operator error, delete. The hell was I going? Huh? You get credit. You're back to neutral. Good. All right. I'm the one with the black mark. I got lots of those. All right. Well, we'll move on. I can't remember what I was going to say because it wasn't very important. So the rate and the tidal volume are determined based on the patient's pulmonary mechanics. The reason I bring this overpriced test lung is so that I can show you, I remember the question. See, it's like the old black and white color TV. You wait long enough and it'll come back to you. So how do I change something, anything? What was the short form instruction for using the ventilator?
Touch it.
Touch it. Excellent. 2 gold stars. So if I wanted to change this display to something else, what do you think I'd do? So touch that display and you'll get a pick list. And select dynamic lung. So I'm guessing that your dynamic lung doesn't look like that dynamic lung. Right? Yours looks like 2 bricks. Okay. Aha. This is awesome because you can see it large. This has normal shaped lung, normal looking airway. That's the static compliance and that's the airway resistance, and those are measured breath by breath from the ventilator, and that information is available by virtue of the flow sensor. And then the ventilator, because we indexed the ventilator and the patient together, didn't we? We put in the gender and the height, which calculated the ideal body weight. So not only does it measure the compliance and the resistance, but it says, how does that compare to a patient of that gender and ideal body weight? Is it normal or abnormal? And then the picture depicts that based on an average of 8 breaths. So these update breath by breath. This is an aggregate of 8 breaths, and it's referenced and compared to what would be normal in the normal range. So compliance isn't a number, it's a range. Resistance isn't a number, it's a range. And it moves up and down based on ideal body weight. And if the values are within the normal range for a patient of that gender and size, you get a little green pencil line around the display. Yours does not have a green pencil line around the display. Okay? So we can just stay on that because we're going to do a bunch of stuff with that. If you would, please. Thank you. So I'm going to change the test lung, and let's see what happens to my dynamic lung. And then you tell me if you speculate on what actually has changed. So watch the numbers and then watch the picture of the lung. And I'll change the alarm limit here so we're not bouncing into that real quickly. So we haven't gotten to that yet. So you probably saw one or those numbers change. So hey, no more green box. Something's not right. So what's different about that dynamic lung display now? Look at the airway. The airway, the lungs are the same, but they're not bricks like yours, but the airways are red and narrowed, and so we have a patient with really high airway resistance. Diagnosed, what kind of patient are we dealing with? So now I'm going to go back to my dynamic lung, or to my ASV graph. What shape was that safe ventilation window before? It was pretty square, wasn't it? Now look at it's tall and narrow. It's like a skyscraper, right? It's got 27 floors, but only 2 rooms wide. And why is that? So now we're getting into the physiology a little bit. So that's what we started with, normal, right? So the shape of that safety frame and the illustration of the pulmonary mechanics on the dynamic lung will be one and the same. And after you use the ventilator a few times, you probably won't even go to the dynamic lung anymore. You won't need to. But it's a good way to check, right? So yours looks like that, right? The safety frame is like a school building. It's got 46 rooms east and west, but only 2 floors. It's not very tall, but it's real wide. Okay. And there's 5 depictions of compliance that the lung shows. There's the normal that we saw before. If I'm going to go back. There's normal. You look up here on the screen, there's normal. There's a reduction in compliance. There's hypercompliant, the big baggy floppy lungs. Then there's 2 more, which is instead of a lung with 4 sides, there's a lung with 5 sides, which would be a little higher compliance. And then a lung with 6 sides, a little higher compliance yet, and then normal, and then hypercompliant. Okay. And then we have the patient with high airway resistance and high compliance, or abnormally high compliance, a COPD patient. Okay. So you get 17 stars and a free lunch for this one. So if you had a patient that started to bite the tube, so they had normal pulmonary mechanics, but partway through the trip the tube gets kinked in the back of their throat, or they bit down on the tube, and you couldn't get them to stop doing that, what would be the most appropriate way to change the way you're ventilating them? Okay, so we're getting into like ventilator strategies now. Okay, so you just ran out of sedative. I got all kinds of excuses. The point is that ventilating patients that are obstructed, so the COPD patient or the patient that has trauma to their airway and you had to put in this really small ET tube, or they're biting the tube, or they have tons of secretions, or a mucus plug, those all from a ventilator management standpoint have to be treated the same way. Don't say never always, but for the purposes of our conversation. So we know that the minute volume that we have to deliver to the patient is based on their metabolic demand, right? So for the purposes of our discussion, let's say the minute volume requirement is not going to change. If I have to deliver 5.7 liters per minute, should I go up on the rate or down on the rate, up on the volume or down on the volume if the patient